Well, good evening or afternoon to everyone, depending on which part of the country you are viewing this from. I'm Dr. Todd Engel, and I'd like to welcome you to Mainstreaming Dental Implant Impressions and Conditioning the Edentulous Tissue. I'm hoping that you'll enjoy our next hour together. If you have any questions, please feel free to prompt them by writing them in the bar below, and I will be answering them as time allows. Just to tell you a little bit about myself, my name is Dr. Todd Engel again. I'm the clinical director and founder of the Engel Institute, which is now in our 11th year with centers across the country training dentists in the arena of dental implant dentistry. As we move along, I will be sharing more here with you, but in the meantime, let's look at our agenda for the evening. So here's what I plan to cover. We're going to start out by a little bit of implant nomenclature. I know that there's various terminology that's used day in and day out. So for clarity and for the purposes of this evening, I'm going to explain the terminology that I will be using. Thus, it'll be a little bit easier for you to follow along. We then will jump into the ever-popular closed tray versus open tray impression techniques, which I'm hoping that a lot of you will pick up some little pearls from. After that, we're going to talk a little bit about the biologics of an implant versus that of a natural tooth. There are some differences, important differences, especially when we're considering impression-taking techniques. We will then go on to discussions about what impression materials we may want to consider, and we'll talk about the importance of a soft tissue model that's done at the lab and what it is that we are looking for in that soft tissue model. And we will round out the hour with conditioning the edentulous tissue. So let's start with implant nomenclature. As you're looking at the implant in front of you, you'll notice that we have a platform, which is the topmost portion of the implant. Now, the platform will always be where the actual abutment interfaces to make the connection. The connection will be made between the abutment that's holding the prosthesis, whether it's a cement-retained or a screw-retained prosthesis, and it will join the implant at the platform level. Next, we'll have typically a reverse bevel. In the implant that you're looking at on the screen, this is a Legacy 3 implant, direct implant, and the reverse bevel is used for a number of reasons. One is to elevate or raise the connection of the actual platform and the abutment to keep it away from the level of the bone. The other thing that I find really interesting is it helps prevent bone loss in many cases, as that's actually countersunk below the level of the crest. Moving along, many implants are now designed with mini, or what you might call micro threads. And what this does is it pacifies, or it actually disperses the stress around the neck of the implant, around the bony area, to help prevent or reduce the amount of actual bone loss after the implant has gone through the surgical healing and the prosthetic remodeling, which can take anywhere in total from about 6 to about 8 months. The implant, which is commonly called an implant, is referred to as either the implant body or the implant fixture. And I say this because when it comes time to discussing impressions, we hear different terminology. We hear implant level impression, we hear fixture level impression, we hear abutment level impression. So we're going to clarify those terms. But it's important to know that the implant is actually called the implant body or fixture. And then lastly, many implants are designed with what we call self-tapping grooves. In other words, osteotomies are prepared slightly smaller than the actual size of the implant. When we look at different types of implants, we're going to compare, just for the purposes of nomenclature and understanding, we're going to look at a tissue level implant as well as a bone level implant. If you'll notice, the red tissue line on both examples is in the exact same position. So when we take our impression, we are capturing the entire impression, including the level of the tissue. Now, the difference between a bone level implant and a tissue level implant, they both are what we call one piece, and we will get to that a little bit later. So when you look to your right, the tissue level implant is actually one piece. That is not a detachable piece. There is some belief that certain individuals prefer the connection of the abutment to the implant, highlighted here in purple, elevated in what we call a transmucosal fashion. In other words, if you look at the implant on the right, that's a one-piece implant where the gray or treated surface is placed in bone. The shiny or polished surface actually extends through the mucosa and is either captured directly at the tissue or slightly below subtissue level where the actual abutment to implant connection is made. On a bone level implant, what you have is you have the first portion, which is the actual implant body or fixture, placed into the jawbone at the level of the bone typically. And then you have yet a second piece, again highlighted here in purple, which would be your abutment. Now, this gives you many more choices or options. So if you're first starting out or you're new to the surgical apparatus of placing dental implants, this would give you more flexibility in an implant that may be not ideally positioned or not parallel with another implant. The more connections we have, the more variations or the more options that we have. Lastly, when we look at one-piece versus two-piece implants, kind of like I depicted on the last slide, a one-piece implant, in my opinion, is extremely limiting versus a two-piece. When you look at a one-piece implant, which you're looking at the one on the left, you have the implant body or fixture. In some cases, you have this polished transmucosal portion, which is about anywhere between 1.5 millimeters to 3 millimeters tall. And then you have a built-in definitive abutment, which seems handy. And many years ago when I began, I used to look at this like a one-stop shop, almost like a very practical, less expensive purchase to go ahead and place implants. However, again, if you're malpositioned, malaligned, or if you have an implant that lacks some integrity or lacks some initial stability and you choose not to load the implant, this is very limiting. So my recommendation, this is just my personal preference, is to go with a two-piece implant, again, offering us many different options and many different ways out, if you will. I want to just share with you the term single-stage surgery versus a two-stage surgery. The image that you're looking at in the picture, for clarification of terminology, we're going to call this a healing abutment. It's also known as a healing collar. It's known as several things, but for today, we're going to call this a healing abutment. Now, a healing abutment is placed on an implant with the ideal torque or initial stability when that is achieved, which is typically plus 25 Newton centimeters. When you place a transmucosal healing abutment like this, trans across the mucosa, transmucosa healing abutment, what happens is this healing abutment is now in the oral environment and it's subject to chewing, tongue thrusting, etc. So before you place something like a healing abutment on the implant, you want to make sure that it's received an initial torque or initial stability. My recommendation is 25 Newton centimeters plus, to make sure there is no micro movement within the implant body, because this will be a problem as it all is creating a fibrin clot and trying to do its initial healing in the first 7 to 10 days. So when we talk about a single-stage surgery, when I lecture, the best way I explain it is this: how many times are you going to do a surgical procedure on this patient? Well, in this particular case, it would be 1. So we place the implant, we control the osteotomy, we place the healing abutment, we get good initial stability, and when the patient comes back, we don't even require an anesthetic to remove this. It's simply removed with a hex tool, and an impression is then taken. Now, when we look at a 2-stage surgery, this could be for a number of reasons. In this case, the image that you're looking at now is where I had done an immediate extraction and implant placement, as well as graft. Now, a cover screw versus a healing abutment is placed on the implant for a number of reasons. Either it can have very little torque or initial stability, or in this case, maybe we were concerned about bacterial contamination and we wanted primary closure. Or lastly, even in an aesthetic area such as this, having a healing abutment might make things difficult when it comes to temporization. But when we talk about cover screw, a majority of the time we're talking about placing this on an implant that has a minimal to very little initial stability, thus requiring us to go in and open the implant area up for a second time, or what we would now know as a 2-stage surgery. Moving along, as you can see in the image, you see what we're looking at now. These are what we call fixture mounts, and these are implant direct fixture mounts. They come in various forms with various companies, but what I'm trying to explain here is there's different ways to capture an impression of an implant. The term fixture mount is used in impression coping, transfer post. I like to use the term fixture mount. And this type of fixture mount, if you look at it, it has a couple parallel walls, it has some undercuts, and this is really beneficial when we take impressions because it captures the wash material as well as the tray or body material without displacing the fixture mount or creating any rips or tears. So when we look at this type of apparatus, this is when we get into thinking, do we want to have an open tray approach, or would we like to consider the closed tray approach? Now, what you're looking at here, where you see a single unit being impressed, this would be a closed tray impression technique, which I'll get into in a little while. This is very similar to a typical crown and bridge technique where you would prepare a tooth, you would put on whatever material it was to displace tissue, you'd capture the preparation of the natural tooth with a wash and a heavy tray body, and then when you went to remove the tray out of the patient's mouth, very obviously the tooth would remain. Well, that's the same case here. We would place a wash material, we would place a tray material, we would place the tray in the mouth. After the set time was complete, we would remove the tray. This closed tray impression coping would stay behind, much like a natural tooth. At that point, we would then remove this with the driver and place something like a healing abutment to prevent the tissue from closing again. When we talk about a fake implant, let's call it, or the implant that is going to be placed into the cast to replicate what the patient has in the mouth, we refer to this mainly as an analog or a replica. Choose your weapon. In my world, I refer to it as an analog. And what the lab will do is they will place the lab analog connected with the fixture mount that you had used to take your impression, and they will do a reverse pour. Thus, when they separate the cast from the impression, you will have, as you can see here in purple and green, you will have the implants replicated on the cast exactly as though they are in the mouth. So let's move along now, and let's combine a couple things together for the sake of time, because I feel that at the end of this program you're going to have some questions, and I want to get to as many as I can. So what we're going to do now is we're going to combine the closed and open tray techniques, and when I personally use them. I'm going to discuss the biology of the implant versus the tooth a little bit. If you remember it from dental school, that's fantastic. If it's something that you don't remember, I think this will give you a really good bird's eye view of some really important concepts of it. Next, the impression materials. Now, I have been using a certain material for several years, going on 9 years, I've been using the same material in the program and in private practice as well, and I'm elated with it for a number of reasons, and I'm going to share what that is. I would like to say that I am a KOL for Kettenbach USA, as well as many other dental implant companies, KOL being a key opinion leader. However, I would also like to disclose that being a key opinion leader, the first thing that I must do is I must use a product that I completely believe in. Getting an honorarium comes a distant second. So let's look at the biology, just simple biology of that of a tooth versus an implant. Now, one of the things that's really quite important that we keep in mind is that a tooth has 3 forms of a blood supply. It has the alveolar bone, it has a connective tissue that is 30% of the bleeding, and a tooth also has a periodontal ligament. Now, when we look at the SEM of the implant, we see an alveolar process, the bone. We also see a connective tissue apparatus. However, we are missing the periodontal ligament. We do not have a periodontal ligament around an implant, which is really important, especially when it comes time to placing the implant. And this is why we talk about certain spacing that is required not only between implants, but between implants and teeth. Additionally, the fibrous tissue in the connective tissue around a tooth is much more greater in volume. In other words, there's much more connective tissue fibers in a natural tooth connection versus an implant. So you have more fibers in a tooth than you do an implant. The problem is that we lack cellular divisions when it comes to attachments around an implant. So in short, what I'm trying to explain is that the attachment, the soft tissue attachment, the connective tissue and epithelial attachment to a tooth is far more sophisticated than that of an attachment to an implant. And when we are already short 30% of the blood supply, meaning we do not have a periodontal ligament around the implant, we have to be careful. We have to be careful about how we approach our impression taking to make sure and not disrupt the attachments that we do have. Again, I've just highlighted in pink for you the attachments that we have for a natural tooth are A, the dental fibers, B, the alveolar process or bone, and then lastly the periodontal ligament, which is absent in that of the implant. So let's look at some impression taking techniques, and we are going to also combine what I've just told you, a simple 2-minute histology on implant versus tooth. The other thing that I do want to mention to you while I am on this slide is this is just my personal preference. There's many great speakers, there's many great clinicians out there, and they do what they do and they follow what works for them, and I completely subscribe to that. However, for myself, based on what I've just explained to you about the attachments to a tooth and to an implant, I am personally completely against placing any type of retraction cord around a dental implant. Because you have to understand that in the most common of cases, we do have some bone remodeling after the surgical placement of a dental implant. If you do place retraction cord in the sulcus, if you will, or if the pocket, if you will, and you do have any exposed threads, that are supracrestal or above the crest, that wash material or even body material could get down in there and get wedged in between the threads of the implant, which are extremely difficult to see and remove and ultimately are quite painful to the patient. So when you look here, if you could see my cursor, just to give you an idea of what I was speaking about the attachment, this is your connective tissue attachment right here, from the tissue to the tooth. And you will see that this is in a perpendicular form, meaning they are going perpendicular into the cementum of a natural tooth. So when we talk about the attachment here, it's very organized and it's very strong. Now, if I come over here with my cursor and I curse up and down here to the, let's call it the left side of the implant fixture, and then I come over to the right side of the implant fixture, you will notice that the connective tissue attachment is not very organized at all. Additionally, it is parallel to the implant versus perpendicular. So impression taking around the implant has never been so important as it is now, especially understanding the histology of the attachment. The last thing that we want to do is go through the surgical protocols and get everything correct and have just a really well-placed implant and then disrupt the attachment when we go to take the impression, leading to ultimate aesthetic failure and possible surgical failure even after the implant has been integrated. Okay, well, let's look now at open tray and closed tray techniques. And what I'm about to tell you is the techniques that I subscribe to. They've worked for me over the last 15 years and 9,000 implants later. So just like anything else, if it works for us and we're happy with it, why change? Okay. What you see here now, I felt it was just much easier and cleaner to show you on a demonstration model, is you see a fixture mount. This would be a closed tray impression technique, as I explained earlier. The indication for this in my office is when you have a single implant that is fairly parallel, or two implants on the same side of the arch that are relatively parallel. As we know, the jaw has two curves. We have the curve that goes superior, and we have the curve that goes lingual. And if we are placing an implant in 19 and 30 at the same appointment, if these are placed in an ideal situation with the curve of Spee, curve of Wilson being correct, they will converge towards each other as you go superior. So what I'm basically saying is they will not draw. 19 and 30 will not draw. And if you go and use this closed tray impression technique, where the fixture mount remains in the jaw even after the full arch impression has been removed, if these stay in, they will win over the material as you attempt to pull the tray out, and your impression will be distorted and or torn. Okay, I'm a big believer of what we call initial compact or wash material around the fixture mounts, regardless of what type of technique I'm using, a closed tray or an open tray coping technique. And the reason for this, mainly in my opinion, is the difference between looking at a dental implant that has been prosthetically finished or restored, as we like to call it. The difference between looking at a dental implant that has been restored and saying, wow, that looks pretty good, versus looking in someone's mouth and saying, which one is it? Where is the implant? In my opinion, is entirely up to two things. Let's assume that the implant has been placed correctly. In my opinion, the two things that remain are, number one, you obviously have a good lab that you're working with, and I would like to plug my lab. They're my family, not literally blood family, but I've been working with them for so long. They are like family. It's Drake Lab out of Charlotte. They are absolutely wonderful. Our labs do not get enough credit for the beauty that they provide for us, so I want to give them a little plug and thank them. But the second thing, and the most important thing in our hands before it comes time to complete the case, is the periodontium, the tissue. The difference between looking at a fixture or an implant that has been restored and not knowing which one it is versus being able to pick it out, assuming you have a great lab, that difference is solely in the tissue. And if you have treated the tissue well throughout the entire surgical process and temporization process, etc., then you would be discounting yourself if you didn't provide the information of that tissue to the lab. So I want to share with you this material that I came across roughly 8 or 9 years ago, and I absolutely love it. This is called Panicil. It's from Kettenbach, USA. We call this the initial contact. I use the extra light material. And I'm going to go over something called contact angle in a little while. And I'm going to explain in one slide, hopefully eloquently, to make you understand why we use what we use without getting into too much about dental materials. We don't have the time for that this evening. But this is the same material that I use on every single one of my cases, regardless how big or small, and I have been using on every one of my cases for the last 8 or 9 years. Again, this is called Kettenbach. This is Panicil. This is what we call the initial contact. And what I do is I use this initial contact covering the entire abutment portion, which in this case is the silver portion, the green portion after the transfer is done to the lab. The lab will pour it up and then cut off the green portion. I cover the entire silver part to make sure that I have the opportunity for the material to displace. Now, speaking of displace, I put this on here for you, and we're going to see a very short video. It's not more than 20 or 30 seconds, and it shows how certain materials act in the presence of sulcular fluids, water, blood, you name it. So we are going to look at something called the contact angle. Now, when you see a liquid hit any type of impression material and displace flat, that means that it will not bundle up and create a bubble inside your impression. When you see something hit material like blood or saliva or even air and not displace, that ultimately will come in the form of a bubble in your impressions. So if you feel like you take pretty good impressions, you get good retraction on natural teeth or no retractions on implants, and you can't understand why it's not as clear as it should be, or why you're getting bubbles when you've isolated, you've done everything you can, I want you to know that some things are not in your control. And one of the things that is not in your control is how the material displaces when it hits certain material, how the liquid displaces when it hits certain material. Even if it is a hydrophobic or hydrophilic material, you will be told it likes blood, it likes saliva, it likes water, it has no problem with sulcular fluids. That's fantastic, but what happens when it hits it? That's the question, and I'd like to show you this. So what you're looking at now is you're looking at impression material that you're going to see 3 drops being placed on the material, and the drops basically are referring to what's in a sulcular or crevicular fluid. When you look at something like a 3M, these 3 drops are placed. Now this was the last published information, and it shows that this does not displace. Okay, so when you compare 3M to the initial contact that I was talking about earlier, you can see, and you'll see it a little bit later, you'll notice you put the saliva on the material, or the saliva hits material, it doesn't go anywhere. So that is going to transform into air. When you look at, I'm going to pause this for a second, when you look at the Panicil, as I was explaining to you, it displaces. So when the blood or sulcular fluid or water hits the material, it displaces, so there's no error. When we look here at 3M or Aquacil, as the contact angle will show, this information is available to anybody, after the same material is placed onto the respective materials, let me clarify something because I use materials twice. After the imitation crevicular fluids have been placed onto both materials. They do not displace. So what we're looking at, and I'm going to show you in a second, is the angle is measured. The angle of the bubble is measured. And when you measure the angle of the contact bubble, the smaller the angle, the more displacement. So, as we continue to look at this for another 10 or 15 seconds, you will see that it will now show contact angle. So, when they look at Panasil, what you just saw in the previous section, when Panasil when blood or curvicular fluid is dropped onto Panasil, it displaces and flattens out to a 9-degree contact angle, which is superb. When you look at the next one that we viewed, which is the affinis, after it displaces, the contact angle is 50%. That means that half of the bubble displaces, half of it doesn't. Now, is this a hydrophilic material? Sure it is, but does that mean that you won't get a bubble in your impression? Absolutely not. Looking at one other, if we look at Aquasil and the contact angle of Aquasil, it's a 48% angle. So it is going to remain a bubble. When the fluid hits the material, it will not displace. So regardless how you're using it, that will stay at a 48-degree angle, creating a bubble within your impression. And then lastly, we're going to end with Improgum. Great products. Improgum has now a published 49-degree contact angle. So that is going to ultimately come in form of a bubble in your impressions. And unfortunately, sometimes we see them and many times we don't. Alrighty. Moving right along. When we talk about a body or a hard or body material, we also use a Panasil material. I do, even if it's a single unit, I'm proud to say that in the last year I've probably had maybe 1 or 2 remakes in the entire year. And I think that it's very controllable. We all can control that. We all can control the remakes, providing, again, that we're using the right materials in the lab. And it just takes getting good information. So in all of my cases, whether I'm doing a single unit or multiple units, I am going to provide a full arch, no triple trays. I don't even have triple trays in the office. I want something rigid. I'm going to provide a full arch placed on the specimen or the model or what have you that is going to include initial contact around the fixture mount or even around a natural tooth. I am going to also provide a full arch lower impression as well as a bite. Now, for some of you, you may be doing it already. Hopefully, most of you are. For some that are not, I want you to know that the time that you are saving by not doing that ultimately will equate in 3 or 4 folds of time later if you have a remake. If a lab has a very clear and concise full arch impression, and which includes a wash, as well as a full arch opposing and a bite, again, provided that you are using the correct lab, there should be 0 problems with that. You will turn that into an occasional phone call with an issue versus many phone calls. Okay. As I mentioned, in a closed tray technique, you can see here we have the Panasil body and the Panasil wash or initial contact. The colors are dynamic, which is fun. But when we remove the tray from the jaw, again, the impression copings or the fixture mounts remain in the jaw and the full arch impression comes off. Okay, let's look at open tray impression technique. Now, just to reiterate, I'm going to use a closed tray technique with a single unit or 2 units that are relatively parallel on the same side of the jaw. When we look at this model, I purposely placed the implants slightly more divergent away from each other. So as I was saying earlier, as you go superior, these are going to become more divergent. So if you attempt to pull out a tray like we do in a closed impression coping, in a scenario like this, you will absolutely tear the impression on the way out. So now I'm going to describe an open tray impression technique. Open tray copings are required. They're anywhere between 20 and 40 bucks. And we can reuse them, sterilize and clean and reuse them. And what happens in this case is the implants are placed, the fixture mounts or whatever the implants originally come on are removed, and we now have an implant in the jawbone, or in this case two. We are going to take these off. We are going to put on our open tray impression copings. And as you can see, they're placed in here. They're screwed in and just hand tightened with a thumb driver. And you can see here again, with the angle of the photo, that the divergency of the impression copings would never allow you to pull out an impression tray with a good draw without tearing them. So let's look at how we do this now. The first thing that we're going to do is we are going to try in a tray, okay, and we are going to make holes in the general area that our impression copings are going to come through. You can see on this one I didn't do too great of a job, did I? But nevertheless, I also have a hole cut to show me where a natural tooth is. And it's a window, so I know that I'm completely down, and I can see once the material extrudes out of this area, and I can see, like over here, you can feel and see that the tray is seated. Now what you want to do is you want to try this in the patient's mouth, and the view of the photo looks like this may be hitting, but it's not. You want to try it in the patient's mouth and make sure that you can go in and place this ultimately into the patient's mouth and have the two impression copings peek through. Now, some people put certain things in the top of the copings, like you can put a coffee stirrer, you can put wax. There's a number of things that you can put in if you're concerned about material getting in here on its way into the mouth. I don't, and even if I do get some material in there, as you all know, if you just let it dry for 4 or 5 minutes, flicking it out is not a problem. Okay, moving right along. So much like the closed tray impression coping technique, I'm going to go around the open tray impression coping with my Panicel initial contact, and then I'm going to load the tray with the Panicel body and place it directly in the mouth, exposing the two open tray impression copings. And about 4 minutes later, after this is firm, this is where it differs. When we remove the tray, we are now going to use a thumb driver. We are going to loosen the screw on both sides through the tray before it is removed from the patient's mouth. After we know we have both of the screws unscrewed, we want to make sure that we can pull them up and down. So if you see my cursor on the top right, you want to grab this screw and see that you can pull it up and down. My recommendation is make sure that it will come all the way out, but don't take it out, because there's not a lot of room to work in the patient's mouth, as you well know, so you do not want the patient swallowing this. Okay, now once those are loose and we pull off the impression, the full tray, now what you see is the green part is embedded within the impression. Okay, what you're looking at here are lab analogs. That's what the lab will use. They will connect the lab analog to this internal aspect of the open tray impression coping. The lab analog will be sticking out towards us, and then we'll do a cement pour and then ultimately separate. But the main thing here when we talk about the open tray technique is the coping is frozen within the impression, and it shouldn't move. So when we go to pull out the impression, it is now giving up at the fixture level of the implant versus tearing around a fixture mount. Anybody have any questions on that? If you do, go ahead and ask away and I'll be happy to answer. So again, closed tray impression coping that's captured within the impression. It comes out with the impression. The lab analog is placed on, and then the case is poured up. I just want to mention that the product line that I use, as I mentioned, I use the Panasil, and it comes in various forms and viscosities, etc. You just have to find something that you like, or maybe you already do use a medium, a high, whatever the viscosity is. But they have a number of different materials that are just incredibly good. Here on your left, I use their bite as well. It's called Futar, and it comes in different setting times, and it's rigid. You can use it multiple times over again. It holds its body quite well. And then over here, I have to tell you that the product that actually got me so enamored by Kettenbach many years ago is this product called Silginate. And this is the alginate replacement that comes out of the machine. And what's incredible about the Silginate, aside from not needing water and mixing bowls and being cheaper than alginate actually, is it's a VPS material. It's a polyvinyl siloxane material, so it holds its body. So you actually can get 3 pours out of 1 impression. Additionally, it does not have to stay wet, so you don't have to wrap it or pour it up immediately on the busy days. And then lastly, it will not lose shape, excuse me. It will not lose shape. It will remain form for 3 weeks. So it's pretty incredible, especially on those Fridays when we just don't have time to get to pouring up models. Okay. I'm going to show you a case, and we'll kind of take this through. This is a sinus elevation case that we do in all of the programs I teach. The Engel Institute has various programs, what we call Mentoring 1, Mentoring 2, Mentoring 3, and soon to be Mentoring 4. We've been teaching these around the country for, this is our 11th year, and I pride myself on the fact that all of the attendees, regardless of where you live, all of the attendees work on live patients themselves. So this is Mentoring 2, which is a class where you place an implant, you do a sinus elevation, or in this case a sinus bump. So here we are, just walking you through a couple little cool things here. We are entering with the pilot drill. We're about 1 millimeter below the sinus here, and to make impression taking fun, I think everyone should bump sinuses, right? And then we teach you how to elevate the sinus floor, as you can see here, with osteotomes, various size osteotomes, a small size, a medium size, etc. We also go over a lot about how to graft materials, allograft, autogenous bone, xenografts, alloplasts. We talk about cancellous tissue, demineralized tissue, cortical tissue, mineralized tissue, and all the combinations of how to use everything. And in this case, what we're looking at is adding bone into the osteotomy. So when we elevate the sinus, we can have bone around the apical portion of the implant. But again, these are all done by the attendees, and it's quite exciting. So here we are. The implant is ultimately placed. This one was done in one of the classes by one of the attendees. We remove the fixture mount, and this, again, will be placed on down the road later when we do catch the impression. But again, this is the surgical day. There's the implant placed just below the gum, and then we're going to go ahead and torque it down to the level of the bone. And here we are, case complete. You can see here's the cover screw, which we like to do when we graft and we sinus bump. We don't want to keep it open for too long. That's just my preference. And here is an implant placed by an attendee, and here's the graft here, which is kind of neat. Moving right along. Here is the case at 4 months. Wow, what an incredible job this person did. And you can see that the bone is remodeled really nicely right up on the apical portion of the implant, and the new floor went from here to now here. So what we're now going to do is we're going to take what's either a laser or a tissue punch or a burr, whatever your fancy is. In this case, we used a tissue punch. Obviously, the patient's numb. We are creating a little tissue punch and removing the tissue punch with the tissue forceps. As I explained, this is Mentoring 2. Additionally, besides sinus elevations, etc., we also provide a live extraction patient for all the attendees, where you will remove a tooth, you will graft the socket, and you'll know what you're grafting and how long you need to wait. We will also be placing membranes, moving tissue, suturing, and what's really fun is it's all done by the attendees under the supervision of the mentors, and you go home with a nice recipe that allows you to do this when you get home. And it's amazing. It's incredibly profitable. And by the way, I don't think I mentioned it, but I'm a general dentist. I'm not an oral surgeon or a periodontist. I've just dedicated my life to learning how to do implants, and moreover learning how to teach implants. I think it's a fascinating field. The biggest part of all dental platforms right now for us in dentistry, and I hope that you take the time and learn how to do this, because it's very rewarding, pretty incredible, and quite frankly, many implants that you're referring out you probably could be doing yourself if you educate yourself appropriately. Okay, so there I am. If you don't know me, that's me, and this is one of the Saturday courses. Typically each mentor will take 6 patients, and every attendee will go through and do all of the stuff that you've been seeing. And if you ever have the time to read about what I do or who I am, you'll see I really believe in you doing live treatment on live patients, not cadavers, not animals, not watching me or an instructor do one. It's really about 4 hands, and 2 of those hands are the attendees. So if you're interested, you can certainly look that up as well. Okay, so here we are 4 months later, and now we're going to prepare for the impression for this case. Very nicely done. So we remove the tissue tag. Out comes the cover screw. Now here goes on the fixture mount, the original mount that came with the implant. And again, I'm doing a full arch impression. This is going to include a wash. I want to capture all this nice tissue, and I'm going to talk to you about how papillas can be made or created with the right prosthesis. I'm going to provide a full arch opposing, and I'm going to provide a full arch bite. You know, guys, it doesn't take a heck of a lot longer to do what I'm suggesting versus a triple tray or a case without a bite. Do your dentistry and avoid your lab calls. Your lab shouldn't be calling you, telling you that they need more information from you. It's a big waste of time if this is something that you are seeing a lot of. Provide them with the information and then go do your dentistry. All right. So here we are. Again, just to recap, we've made a punch. Okay, we've removed the tissue. We have placed the fixture mount back on, and you can see here, you can see, as I was talking about before, there's a bevel there, and the implant has actually retained all of its bone. In fact, it's actually had some growth over the bevel. This Legacy 3 implant from Implant Direct, this is what we use in the courses, and just beautifully done. This is just a classic case. Many of these you see now. Hopefully you're not walking a lot of them out. And continuing on, here's my Panasil wash, as I mentioned, and I will cover all of the silver part. Take your time, and it's kind of like, you know, Van Gogh. Just take your time, make sure it's nice and dry and clean, and a full arch Panasil body. Okay, I prefer disposable trays. If you find that this is bumping in the back, take out your little heat lamp. Just run your heat lamp over the backs of it, get it nice and warm, and just take a towel, not a paper towel because it'll stick. Take a towel and just with your thumbs, just bend this out away, and you can create little posterior wings, and it's kind of cool. It works really well. I had a case yesterday where I had a lady who said, no one ever can take an impression of me because I have wisdom teeth that poke out to the side. So I heated these up, I bent them out, put them in her mouth, and she was pretty impressed. So there you go. That's a trick for you. But look at this. I mean, anybody should be able to make a beautiful prosthesis from something like this. Now, if you look here, this right here, this area where you have purple, dark purple, into a medium purple, into the orange, if you could see the cursor here, that's where the fluid displacement happens. And I can tell you that when this crown inevitably seats down, this crown is going to look like it's growing out of the tissue. Okay, so here we are, and you're going to see this slide, this exact slide, in a minute or two. And there's a reason that I'm going to show it to you again. But what happens here is I'm going to explain what a soft tissue model is in a minute. But in this case, it's been removed. And the reason for that is this is time of placement, and you'll see that this will absolutely disappear in a week or two, and the papilla will be filled in, and it will look absolutely stunning. Now, the way that we do this is we can create a papilla in many or most situations if the contact of the two teeth is at 4 millimeters coronal to the bone. And in this case, the cast at this level, we've cut more away here, but the cast at this level represents the bone. So the soft tissue is removed. And the reason for that is we want to make sure from this area right here, this point right here, that 4 millimeters up, the contact is made. Like here, you could see 4 millimeters coronal to the bone. When it's 4 millimeters coronal to the bone, we will suffocate, for lack of a better word, a papilla into formation. Now, keep in mind that if a patient has been missing this tooth for years, from this tooth to the posterior tooth, you have a flat ridge with no papilla. So in some cases, we get very perplexed about how are we going to create a papilla. I'm here to tell you that most of that, a lot of that, is done in the position or contact of where you place your crown. Now again, if you want more information, you can call Drake Lab in Charlotte, North Carolina, and you can ask for either Mark or Andre. And we've spent years literally talking about Dennis Tarnow's study and how to create this. So if you want good, healthy papilla, recommend that you call them and speak to them. Okay, so let's move along now. I want to talk a little bit about the soft tissue model and the importance of that as we wind down here. Okay, so when a lab gets the impression from your office, the idea about the soft tissue model and mimicking where the soft tissue is, hopefully, or in the case of Drake, for me, what they want to do is they want to help design the ideal abutment, the ideal contours, to keep not only the prosthesis happy, healthy, and supported, but the right choice of abutment will also support the soft tissue, the connective tissue, the keratinization, everything, which is extremely important in the life of the implant. If you have a lack of keratinization or a lack of attachment, as I like to deeply cover in the programs, what will happen is if a patient is missing a keratinized layer of tissue, the patient will feel more pain, there will be more biological invasion, it will be unsightly, and therefore, especially from the pain, they will choose not to brush it. And in time, what will happen on the facial aspect, and you've seen this on molars without attachment, you will soon have recession to the point where the implant threads can even show. So when we talk about leaving a good keratinization or keratinized attached layer of tissue around teeth, as well as implants, now we're talking about mechanical protection, temperature protection. We are talking about a connection that will allow less bacterial invasion in. Additionally, the top 5 to 7 layers of keratinized attached tissue is essentially dead. So that's why we can brush the gums and they don't hurt. And additionally, it's aesthetic. It's what we're born with. So just to recap, a soft tissue model is designed to offer you, the dentist, the ideal type of abutment with the ideal type of contours. Okay. How this happens is when this is an impression that's cut in half to show you, but what will happen is the impression will be received from the lab. So in this case, this is an open tray impression coping where it's caught within the impression. The lab analog will be placed on, as you see here, and they will be screwed together from the opposite side of the impression. You saw the open tray impression coping screw. That's what will be used to screw the impression coping to the lab analog. From that point, a soft tissue flowable material will be used by the lab, and it will displace after the stone material is run through. And here you see the after effect. So once this is designed we now can get the ideal contour, the ideal abutment to go into the implant to support all of this tissue, to offer health, to offer all of those things that we discussed at the beginning, the onset of this webinar, which is anything that we can do to protect the periodontium, which is the bone, the connective apparatus, the epithelium, everything. It's very important. Again, we only have 60% of the blood supply to an implant that we have in a tooth. Now, this is what I was talking about when we go to make our contacts. If the lab removes this tissue model, which it just peels right out of the stone model, if they remove this tissue portion, you now are down to the level of the bone, and the contacts can be made 4 millimeters coronal to that and help you remodel absent or missing papilla. And it looks something like this. So what we'll do is we'll pick out an abutment, we'll design the abutment and prep the abutment, stock, custom, whatever it may be, and the contacts will be made at 4 millimeters coronal to the bone, and then this will be placed on, and the elegance, the beauty, when it gets to the mouth will be quite nice. Okay. All right, some questions are coming in. And here we are again, and this was just to reiterate the fact that you can create the contour by just peeling away the soft tissue model. Again, Andre or Mark at Drake Lab are just incredible about helping with this stuff. So we've worked, as I said, for many years together, and they know how important this is in my specifications on this. All right, let's end here with treating the edentulous tissue. If you're doing dentures, or you're doing implant over dentures, or you're doing immediates, it's really important that we look at taking care of the edentulous tissue. Mentoring 3, just while we're at it, is a course where you come in, it's a 4-day course, and we design and place between 10 and 15 implants per attendee. You learn how to do guided surgery. You do guided surgery. We restore all the cases. It's a full upper, full lower arch, anywhere between 4 and 6 implants with immediate dentures, hybrids. We go over 3D scanning. We go over inputting the data into a third-party software company like Anatomage, or if you're using Simplant, whatever it may be, but top to bottom, the Edentulous patient. It's the only course like it in the country where you come in and you do surgery on a live Edentulous patient. Okay, let's show you Donald. So Donald came in, 55-year-old man, just really happy guy, super, super great guy. Obviously, you can see that he's got some issues here. And when we look at something like this, there's a number of things that we have to consider. But number one, before we even place implants, we have to make sure that we establish the right bite. We can't place implants and then open his bite up later after the lab says that we have limited space. Remember, once the implants are placed, if the VDO is opened, even a millimeter in the back, which would mean 4 millimeters in the front, you now have a completely different trajectory of the implants, and in some cases you can't use them. But nevertheless, we landed up taking out all his teeth. I want to talk to you about another product that I use from Kettenbach called Mucopren. I've been doing this denture implant stuff for about 12, 13 years now, and this is the best stuff I've ever used, and I'll show you why. So Donald came in. Extractions were not too tough, other than when you see something like this, you want to be really careful to not be too hasty, because some of this facial plate is extremely thin. And even though they look like they're simple to remove, and they probably are, you want to make sure that you don't damage the plate on the way out. Okay, ultimately these are his immediate dentures in place immediately after the extractions. This work does, happen, most of it, before you take the teeth out. Now, using the Mucopren, what we're going to do, or in your case, if you want to even reline, a soft reline or otherwise, we want to make sure that we dull up the underside of the denture, and all of the instructions are in this material. This is the most important part in terms of, for me anyway, using the adhesive. Using the adhesive will extend the soft tissue life of this denture. It will extend the soft tissue reline life of this denture for sure, and I'll show you why. After that, we do our beading, or we put the Mucopren product in,
we place the dentures back in the mouth. We like that little squish effect that happens where it's extruding out the top. And we go ahead and place it in the patient's mouth, making sure the bite is correct, and then massaging the lips. And this is about a 4 to 5 minute process. And after that, we will get some flash. Now, you don't want to cut this off, even at home if you're using another material. What we're going to do now is we are now going to send it into a bath. Just grab a lab bowl, put it to 122 degrees Fahrenheit. Typically, it's the hottest that a water faucet in the dental office will get. So just put it all the way to hot. Let it get really hot, or as hot as it can. Put those things in for 15 minutes. After they have solidified for 15 minutes, then you're going to trim the flash. You'll also get a burr in this kit, and it's really nice. It trims the flash quite nicely. After that 15 minutes and trimming the flash, this felt wheel also comes with it. And as you can see, I'm just rounding the edges. And this is the soft reline into the denture, and the margin is insignificant. You can't even notice the difference. And if you do feel a little edge, then what you want to do is just take a little mucoprin coating agent. This is a silicone sealant, and just brush it on. And here we are, very happy guy. And here we are at 24 hours. So the material is amazing. The only disadvantage of the material, it holds so well that when it comes time to remove it, hopefully you ate your Wheaties and did a little workout, because it's a little tough to get out. But nevertheless, the tissue loves this stuff. This is, again, 24 hours after. And then what we'll do in Mentoring 3 is we'll take the dentures, we'll scan the dentures for the appropriate positions of the teeth, and then be able to place the implants appropriately under the intaglio surface so we can get good prosthetic support later. That's at 3 months. There is one of the arches that we've planned the implants in and placed them. And then ultimately we teach you how to either go to a hybrid, or in this case, just at 6 months from surgery. When he started, I should say, we went to the immediate denture immediately. 3 months later, the implants were placed, and 3 months later, here we are at 6 months post-extraction. We now show you how to use GPS locator attachments, picking them up in the denture, and then ultimately snapping them in and removing the palatal aspect. Here's the lower picture. And I got to tell you, we did 72 of these last year in Mentoring 3, and it is absolutely the most rewarding thing that I do. We are changing people's lives. You can too. For a person to come in the way Donald did and now have this snapped in to the point where he truly can eat apples and taste his steak, because we show you how to actually remove a certain portion of the palate. And got to tell you, big difference. So here's Donald when I met him, and here's Donald 6 months later, and just a really happy guy, much more a healthier guy, a guy that can go out in public, and it's an amazing thing. Just lastly, just real quick about the Kettenbach stuff, I just want to mention to you that if you, I'm going to leave this number on the screen here for a minute. If you want to contact them, there's the number. You can mention Engel Institute, because they will give you a special deal for watching the webinar tonight. I'm not really sure what that deal is, but I can guarantee you that there will be a deal for you. It is amazing stuff, and they have various, just various materials, and you'll be hooked. And one of the greatest things that I really don't like getting into, but I will now, is that they're one of the last remaining companies that go doctor direct. So you will save upwards of 30 or 40% on your impression bill each month, because they don't go through any supplier. They'll sell you direct. They have been the biggest impression material company in Europe for over 35 years, and I put my name behind them for sure. They're a corporate sponsor with the Engel Institute. That being said, we post all these cases on Facebook. If you go to Engel Institute Dental Implant Training and like us, we will share lots of great cases with you. Mentoring 1 is, of course, if you don't place implants, we show you how to place one. And you get to place one. You're given a recipe on how to do it. You actually place one at the class. So you can go to engelinstitute.com if you want to hear more about or see more about what I do and the classes that are offered throughout the country. I'm at every one. I speak at most of them. And we have a team of mentors that do as well. And if you go to the website, you will follow us along and you'll be able to take part in some of these things that we're doing, some of the cases that we're completing, watch some of your colleagues do cases, finish cases, talk about cases. It's a pretty incredible experience. And I pride myself on the fact that we are live. Everything is live, and it's live done by you, which is how you learn. I have a slogan that says, if you hear something, you'll probably forget it. If you see something, you may remember it. But when you do it, you understand it. So we spoke about implant nomenclature. We spoke about open and tray, open and closed impression taking techniques, and the biologics of the implant around versus the tooth. The tissue, the biologics of tissue around the implant and the tube. We also spoke about the soft tissue model, and you certainly got enough on impression materials. And then I finished up with the edentulous tissue. And with that being said, I would like to thank you all for taking part in this. We had quite a large audience tonight. We're coming into summer and graduation and Father's Day and all that kind of stuff. So I want to thank you for taking the time.